it's relatively easy actually. I don't know what is happening. Okay, so it's relatively easy and not a big deal. So I will start from up. Let me go up there. Okay, so the high. Let me take this option. Okay. So the hindgut consists of developing distal. You remember we discussed about the esophagus, mouth, stomach, small intestine, and if you remember, we said what is the junction between the hindgut and midgut? We say is a point between the right 2/3 of the transverse colon and the left 1/3 of the transverse colon. Do you remember that point? Can you hear me?
Yes, doctor.
So last time we said the junction between the hindgut and midgut. I think we should have it here. So if you look at this is the transverse colon here, So if you divide transverse colon into right 2/3, let's say around here, and the left 1/3. So this junction from here, so the right part of this transverse colon, including the descending colon, ascending colon here, the cecum here, okay, the small intestine, okay, all is midgut, okay. The hindgut stops here. So from this point here, that's between the right 2/3 and left 1/3. So the left 1/3 of the transverse colon, the descending colon, the sigmoid colon, rectum, and anal canal. This is the hindgut. Okay, that is the hindgut. Are you following, please?
Yes, doctor.
Okay,
Yes.
very good. Yes. So that is a hindgut. Okay. So what we try to discuss the hindgut now. Okay. So that is the hindgut, and actually this hindgut. So look at it here. In the embryo is here. Okay, in the embryo is here. So this is the hindgut here. Okay, this is the hindgut here. But you know the lower part of the hindgut is expanded. Okay, the lower part of the hindgut is expanded, forming something called cloaca. Okay, this is the cloaca. This extension here. This cloaca is not only going to develop into the lower part of the hindgut, like the rectum, and lower part of the colon, it's also going to develop into urinary bladder and part of the external genitalia. That is why it's called cloaca at the beginning. Okay, but up, if you go up here, look at here. There is also something here. You know, this is called urachus or allantois. You see allantois. So you can see the allantois is continued with cloaca. The hindgut also is continued with cloaca. Okay. So what happened is later, okay, later in summary, this is what happened here. Look at what happened here. Is this diagram clear to you all?
Yep.
Yes, doctor.
So in normal person, the person has the large intestine we just mentioned, descending colon, of course, transverse colon, ascending colon, sigmoid colon, and then rectum. So look at here, this is the rectum. So this is the rectum, this is the part of the descending colon in the primitive fetus. And look at what happened here. This is the anal canal here, or anal membrane. So that cloaca we just saw here, this cloaca, actually is being divided by something called urorectal septum. You see here, this is called urorectal septum. There's a mass of connective tissue, mass of mesoderm, okay, mass of mesoderm and some connective tissue, which will be coming from cranial part of the cloaca, between the cloaca or between, let's say, between the hindgut and allantois here up. And this mass of tissue here, you see, is called urorectal septum. Of course, there's also another mass laterally, but this is the major one here. This mass of tissue will come and will be growing downward, downward, until it reaches this cloaca membrane. The cloaca has a membrane. This one here is called cloaca membrane because the cloaca, the content of the cloaca is not communicating with the outside with amniotic fluid. Remember, there's amniotic fluid all over here. Initially, it's not communicating because there is a membrane there. So that is membrane of the cloaca or cloacal membrane. So this urorectal septum, the aim of this is to continue growing, dividing this cloaca until it reaches the cloacal membrane. And that's what is shown here. You see, if you check here, it is started to growing. I mean, it's starting to grow. Look at here. It's almost there. Can you see the difference between this picture and this one? Can you see?
Yep.
Okay. So you see it's growing downward, this urorectal septum, and it's trying to divide this cloaca into anterior component here and the posterior component. Okay. You see the posterior component, we call it anorectal component or hindgut component. Okay, you can call it any name like. So this is a hindgut component, but the anterior component you can see here is colored blue, but they put bladder here. But here, actually, before it becomes bladder, it's called primitive urogenital sinus. So urogenital sinus is not there at the beginning of the development of the cloaca until the septum, until the urorectal septum develops from the cranial part, goes down to divide the cloaca into anterior primitive urogenital sinus here and the posterior hindgut. Okay, so that's why usually we take the two development together, but here they just say I should teach you hindgut. So I will limit the teaching to hindgut. I will have taught you how the urogenital sinus also develop into bladder, part of the external genitalia and the uracus or allantois. Okay, but later I'm sure maybe next one I will teach. But you have to have an idea that the cloaca is developing into urinary bladder, external genitalia, and rectum, anal canal, and some little part of the sigmoid colon. So this is very important. And that's why they share epithelium after development. So at the beginning, there is a primitive cloaca, okay? And that cloaca does not mean it's just the hindgut. No, it's going to develop into urinary bladder, external genitalia, and hindgut. And the part of the hindgut I mentioned, rectum, anal canal, and the lower part of the sigmoid colon. So that's how this thing develops. Okay, it's quite simple. We just go through the slide and describe more. So this one is just to show us early development. You can see here, this is the cloaca. You can see the allantoid. You can see the primitive urogenital sinus. You can see in this picture, because once the urorectal septum reaches the cloacal membrane and divide it, it will be divided into two membranes now. Remember, it was originally called cloacal membrane, but look at here, it's called part, what do you call it, component in the urogenital, sorry, in the urinary system. The membrane there is called urogenital membrane. You see? Urogenital membrane. And on the hindgut component or anal and rectal component, we call it anal membrane. At this stage, the embryo does not have anus. Okay, does not have also urethra. Other male open, no urethra. They will develop later by rupturing of this membrane. So that's why we say the cloaca membrane is the future anal canal or anus of the baby, and it's also the future urethra of the baby. But that does not happen until this urorectal septum, okay, here, urorectal septum develops and partition or divide the cloaca into anterior component and posterior component, and then also dividing the cloacal membrane into urogenital membrane anteriorly and anal membrane posteriorly. So that's the only time you now say, okay, now we have future anus. But even at that time, the anus is still closed. Because the anal membrane is closed, I mean, the urogenital membrane is also closed. Okay. Now, one very important thing also to mention is The hindgut is supplied by inferior mesenteric artery. This is a small artery here. You remember we said midgut is supplied by superior mesenteric artery. I even show you the superior mesenteric artery is the axis used in general rotation. You remember in the last lecture. So here, this is what happened. At this stage also, you should also learn that. I mean, you should also understand that the stomach, the duodenum, and some part of the large intestine, you see that here, including the developing colon and the rectum, they have dorsal mesentery. They have connection with the dorsal part of the body through the dorsal mesentery. Okay, so very important to understand this. Okay. Now the next one we go through. So this is the same thing, just showing you more what do you call it, more detail. Okay. So the cloaca develops into rectum. You see rectum, and upper to third of the anal canal. You see upper to third of the anal canal. Okay. Lower one third is developing from the ectoderm, from the skin. That's why the lower one third of the anus is sensitive. Okay. If you are cut, you feel pain. If somebody has hemorrhoid, he will feel pain. But the upper one third, that is part of the rectum, no pain there because no nerves transmitting the pain there. And here is just to show you the same thing I just mentioned before. So this is this one is the urorectal septum, okay, and this is the cloacal membrane. So after this septum grows down, you see, it's growing down. And then at this stage here, it reaches the cloacal membrane. So now cloacal membrane is divided into posterior anal membrane and anterior urorectal membrane. Okay, the same thing I just showed in the previous slides. Okay. Then the urinary side I mentioned to you will develop into urinary bladder. Okay. And in the female, the urethra and the vestibule of the vagina are developing also from there. While in the female, prostatic urethra, you see, prostatic urethra develops from the urogenital sinus. Okay. While in the females, the urethra and vestibule, they develop from there. Is it clear so far, please? I'm going slowly and repeating myself.
Yep, it's clear.
Okay, good. That's what I want to hear. Okay, let's move to the next one. So this one is just to show you the rotation, which I've explained to you last time, rotation of the large intestine, okay? So this is the position of the cecum. This is the transverse colon we just talked about. This is the descending colon, sigmoid colon. So in this book, so I think I read, the cloaca does not even develop into lower, what do you call it, lower part of the sigmoid colon. Okay, but if we see, we mentioned that. So okay, in addition to what we said, also dual rotation of the midgut, the descending colon is rotated to the left and the speak. Okay, so I've mentioned this one now. The sigmoid colon remains intraperitoneal in nature, but its mesentery is shortened during the position. Okay, so the sigmoid colon, remember the sigmoid colon, this one here, it has mesentery, so it's it's inside the colon. This one. Okay, sorry. The dorsal mesentery of the rectum and the anal canal is active. Okay, so this is very important. While this rotation is taking place, the mesentery, which I just showed you now, from the stomach to the small intestine to the large intestine, all have dorsal mesentery, but some of them disappear. So like mesentery of the rectum disappear. That's why rectum is just inside the pelvis, surrounded by connective tissue all over. Okay. Okay. So those organs in the body who have no, that are not in the abdominal cavity, we call them retroperitoneal. Retro, that means they are posterior to the peritoneum. Okay, I don't know what I told you this one before. So like the kidneys, they are retroperitoneal. The kidneys are not in the peritoneal cavity. Okay, the liver is intraperitoneal, partially. It's important, but mainly partially. The stomach is intraperitoneal. The intestine, small intestine, they are intraperitoneal. But duodenum, second part of the duodenum, The third part of the duodenum, they are retroperitoneal. They are posterior to the peritoneum. First part of the duodenum is intraperitoneal. Third part is intraperitoneal. So these are just how all this is because of the way the folding, this folding takes place. Okay, so I just mentioned it to you for completing it, but that's what I mentioned to you. This ureter septum, cloacal membrane is division is the most important thing now. So it's the same thing here. Now, one additional information. Okay, you remember we said cloacal membrane is will divide into anal membrane and urogenital membrane. So you remember on the outer part of the embryo there is a epithelium. There is the skin and epithelium. Okay, growing. Okay, so the part of the outer part of the cloacal membrane, okay, or let's say now the anal membrane after division, the outer part, we call it proctodium. Okay, it can also be called proctodium or anal pit, and that's where the future anus will develop. Okay, so you can call once the urogenital septum divides the cloaca into urogenital sinus, you can see the urogenital sinus is developing into bladder. So the lower part will constrict to form the urethra, the upper part or the middle part here will distend to become the bladder, and the uppermost part will actually it will obliterate later in life. And then it becomes something, a structure called uracus. Okay, so it becomes uracus. So what we are saying now is that the ectoderm, okay, the ectoderm, or let's say the skin of that developing embryo on the anal membrane is called proctodium. Okay, and it shows depression. It shows depression that this is going to be the future anus or anal canal. And in some people, in some children, it doesn't open. So some children are born without anus. Okay, so you see here, I wrote here the union of proctodial ectoderm and cloacal membrane with no intervening mesoderm is called the cloaca. So actually, from inside, okay, from inside we also have proctodial, cloacal endoderm. You remember the inside, if you take the cloaca itself, the inside is lined by the endoderm, okay, very important. While here, the outside is lined by the ectoderm, okay, but the proctodium actually is after the formation of after the separation of the or division of the cloacal membrane into anterior urogenital membrane and posterior anal membrane. So the anal membrane is now called proctodium or anal pit. Okay, but whether you are referring to cloaca or anal membrane or this what do you call it? Urogenital sinus. You remember that the inner part is lined by the endoderm, because the endoderm give rise to most of the epithelia of the hollow organs. So from the mouth, esophagus to pharynx to stomach, small intestine line, all these are lined by endoderm primitively or early in the early part of life. Okay, so it's just saying that proctodium is the future anus. Okay, and that's why it's also called anal pit, and it's lined outside by ectoderm, and it's lined inside by endoderm. Very simple, but it will rupture, and then that area becomes the anus. Okay, that's the point. Is everything clear, please? Okay, I'm moving to the next.
Yeah, sure. Fine.
Okay. So, and in some books, they also mentioned that this ureter septum, the endoderm, okay, the endoderm is also called splanchnic mesoderm. I mean the mesoderm. The mesoderm can be also be called splanchnic mesoderm because it's related to the internal structures like the intestine now, the bladder. You know, all this bladder. Sometimes they are supplied in terms of nerves are called splanchnic. Okay. And you remember I told you also that this septum, ureter septum coming from cranial part, on the lateral part inside the pelvis, there are also other tissues or lateral tissues coming to also partition this structure into anterior urogenital sinus and posterior hindgut. So the lateral mesoderm can also be called here a rachis fold, rachis fold, while the urorectal septum can be called two-neck fold. Okay, just now people who maybe discover these structures and describe a lot about them. Okay, so very important to know all this. So now here, okay, so that is what happened. So you have a cloaca, which is the feature rectum and upper part of the anal canal, and also is the feature urinary bladder, and now we know it's also the feature urethra, prostatic urethra, and also feature urethra in female, okay, and the vestibule, okay, in female. So we now know that for this to happen, the cloaca has to be partitioned, has to be divided into otherwise, and we're going to see now, failure to divide, it will lead to problems, okay? So let's see what happened. So this is the same thing actually I'm saying. Okay, so now here is saying that misalignment, okay? You know, lack of alignment or like some problem can happen if the urogenital septum is not properly placed or does not develop properly, and also the lateral fold does not develop properly, can result in abnormalities associated with hindgut and also associated with urogenital sinus. Okay, so let's see. So look at here. The point where urorectal septum intersect the locular membrane in the feature side of the is the feature side of the perineal body, which many clinicians call perineum. So in a baby or in normal person, let me see what I put it there. Yes. Okay. So you remember I didn't teach you anatomy of the pelvis here, but look at this baby here. Okay, I think that's not the best way to explain. Let me come here. Yes, this one. So now here, after division here, okay, after division, you see this area here, this area here, this is the septum has already come. So this area here, dividing the anterior genital anus is here. So the junction between the genital organs, okay, like testes, penile shaft, okay, and this structure in males, that area here is where the perineal body is. Actually, the perineal body is just a point of separation between the anal area and the urogenital area. So that area is very important. Okay, and some author will call it perineum, but you know perineum is also is wider than that. But that area is where many muscles, okay, many muscles in the embryo come there and insert. Maybe I'll show you one or two pictures at the end of this lecture. I will show you one of them. So that is very, very important. So we have development of perineal body, okay? Perineal body, where is the, yeah, so the perineal body is extremely important structure in obstetrics and gynecology, okay? In ONG, when you go to ONG. And it's also important, especially in females. They use it for different, what do you call it, different description or different, what do you call it, surgical procedures in the perineum of the female. It's just to summarize, it's a very important landmark. Okay, once you see, I will show you. Once you reach there, you can easily know anterior to it, whatever structure you see there is in the urogenital system. And when we say urogenital system, we are talking about urinary system and genital system combined. But when we say posterior to urogenital system, we are only referring to the hindgut structures. And remember, when we say hindgut, we are talking about even the transverse colon, right and left one time of transverse colon. We're talking about the descending colon, sigmoid colon, rectum. All these are hindgut. Okay. So perineal body is very important. Okay. So let's see next one. So I mentioned all this. So now what happened if there is no fusion, okay, or there is abnormal fusion or abnormal separation of the urogenital sinus and hindgut posteriorly. So when that happens, or when there's that failure, a lot of things can happen. Okay. So if that happens, can you see here? Can everybody see this, please? Can everybody see this picture?
Yes.
Yes.
So look at this picture in this baby, okay? So look at what happened. In this baby, you see in males, when the septum does not, but you see, this is the anal pit here, okay? Can you see the anal pit?
Yes.
Okay, so anterior to the anal pit, we're supposed to see urogenital membrane. You remember we said the cloacal membrane is divided into anal pit and urogenital, or let's say anal membrane. Okay, let's put the membrane and the urogenital membrane. But in this patient, okay, what is interesting is that this is the urogenital. Previously, this is a urogenital septum here. This one here. It's supposed to come down here. You see, you remember it comes down to the perineal body here. The area here we call anal area or anal triangle are the areas in the anal region. Okay. Anterior to that, those areas are urogenital. Urogenital because there are a lot of urinary structures and the genital structures. But they are separated, the two are separated by perineal body. Remember, I mentioned to you that. So now here, because of the failure of the septum to descend and partition this into two, look at what happened. This is the hind colon, the hind gut. So this is the sigmoid colon here. The sigmoid colon did not come down to form the rectum. So this is the lower, maybe we're looking at the lower part of the rectum. And look at that, it joins the neck of the bladder. So it joins the neck of the bladder, and this person will be born without the anus. So there are babies born without the anus. And what could have happened is, so what we just described here. The urogenital septum and also the lateral septum we mentioned do not grow properly. So they don't go down until they reach the cloacal membrane. And if that happens, the anal pit will be there. So when this child is seen, you see as if he has an anus, but when you put your finger, it's blind. It's blind, it's just small depression. Okay? And this baby, some of them, they will urinate. You see, the urogenital sinus has developed properly. It has bladder here, neck of the bladder, maybe small prostate is there, and this is the penile shaft, and this is the urethra. So the urogenital sinus has developed properly. But the hindgut, the lower part of the hindgut, the rectum and the anal canal did not develop properly. So what happened? What happened is, in this baby, when they urinate, because they will urinate, the urine will contain something called meconium. Meconium is a small, what do you call it? Fluid that is coming from the newborn baby in the anus. Because they didn't eat any food, so they don't have feces. But you remember they swallow the amniotic fluid. The baby drink a lot of amniotic fluid during intrauterine life. So therefore, there are some little discharge from the epithelium of the rectum, okay, and that also intestine. When they mix with this amniotic fluid, they form a greenish or light greenish structure called meconium. So meconium is the fecal matter, okay, of the baby, but it's not actually fecal matter, it's just a secretion. So in this babies, because they don't have, usually we see the meconium in the anus, but this one does not have anus. And the lower part of the hindgut or of the colon is communicating or is having a communication with the neck of the urinary bladder. So when this baby, when this baby urinates, this kind of baby, and here you cannot know whether there is no anus. I mean, if the baby is just born, you are looking at it, you see depression there. So nobody would think, oh, this baby has no anus until after maybe after later in the day or after 2 days when you start feeding the baby with milk, and you find that the baby does not pass any feces in the anus. And also you find that the baby will start to vomit. Then you know, oh, the baby is sick. But at the initial part, you need to, there's problem there. What we see, the only thing you notice is whenever the baby passes urine, you find that the urine is colored. The urine looks mixed with that meconium. That meconium, remember I told you, the feces, the early feces of the fetus. So once you see a baby, newborn baby, the urine should be very clear. Okay, the urine of the baby should be very clear, no any color. But when you see it's very colorful, maybe greenish or dark, yellowish or something like that, there's problem, big problem that requires operation. So I mean the cloacal, there is imperforate anus. Okay, that's why it's good to to go and develop and to deliver in the birth center so that they can examine your baby and tell you whether the baby is okay or not okay. Because no need to, it's not nice you deliver a baby, you come home, and then you have to go back to the hospital and stay there for some time. So you can prepare your mind from the beginning. So all this abnormality can be detected, okay, using modern ultrasound now. So that's why I say you can, people can prepare. So once you tell somebody, oh, there's a, so when the baby is delivered, it can easily be taken care of. So that's what happened in males. Okay, in female, you remember we said the vestibule and the urethra in female develop from urogenital sinus, while prostatic urethra develop from in male develop from urogenital sinus. So in females, you see here, this rectocloacal fistula that involve the rectum. Sometimes in female, you can have recto vaginal fistula here. So instead of having communication here with the bladder here in the males, in female, you see the bladder is far away. There is a uterus here. Okay. So even if they communicate with the, here is communicating with the vesicle, it's easier to open here because there's always the only structure anterior to it. But here there is female genital organs here. So it will form a fistula here, either with the uterus or the upper part of the vagina here. So if it is here with the rectum, you call it rectouterine fistula. Okay? Rectouterine, from rectum to uterus. Or you can call it uterorectal fistula, the same. And if it is having fistula with here with the vagina here, we call it recto-vaginal fistula. And the same thing. So let's say here, the meconium will be coming out through the genital vagina here. So in female, the chances is you see meconium coming. If you see imperforate anus in female, you look for meconium here. If you see imperforate anus, okay, if you see imperforate anus in a male baby, okay, look, then watch out for meconium mixed with urine, okay. While here, you see here in the female, it's real meconium will come out, okay, because there is no secretion there at that stage. But in males, you see because of urine, it's urinating, so it will be sending mixed discharge. Is it clear, please? So far, I have taken a lot of time explaining this. Is everybody clear?
Yes, it's quite clear so far.
Or are there any questions? You're about 70 students. Any questions so far? Okay, I'll finish in 10 minutes time. Okay, so great if you understood. So here we said the center I just mentioned, rectovesical fistula. So again, in female, you see the abnormality can be severe. It can also lead to the production of duplicate genital organs. You understand? Here, like here in female, this could disrupt the fusion of the paramesonephric duct, producing paired bilateral vaginas and uterus. So some women can have bilateral uterus, all because of the abnormality of this partitioning of the cloaca. So partitioning of the cloaca is very important. That's why if you go to surgical neonatology, you see a lot of cases, abnormalities. The pediatric surgeons are doing a lot of work there. So you can repair. If somebody is born like this, you can repair it. Okay? You can correct it here. You can correct the anus here. After correct the anus and it's functioning, there's a way you can make it function. After you correct the anus and it's functioning, then you go back to surgery, go back to the theater, and go and cut this one here. So you cut this blind, not blind now, the communicating stalk between the rectum or the sigmoid colon and bladder. You cut it here and you switch here. And then you bring it here. If you have created the anus, you now anastomosis with the anus. Something like that. So this is the same thing. This is the rectovaginal fistula I was telling you. This is the, okay. So here it's saying that in males, a fistula is formed between rectum and the prostatic urethra. You see, in males also you see this thing, it can happen anywhere. So you can also have fistula. Okay, fistula generally, fistula is communication between two epithelia. So if you have epithelium of the rectum and the skin, so the rectum sometimes can open into the skin of the outside. That is a fistula. If you have now here communication between the rectum and the uterus, is also fistula. Communication between two different epithelium, or let's say two epithelium. They don't have to be different. But for simplicity, we can say that. So let's say here you have communication between the vagina here and anus or anal canal here. If it is anal canal proper, okay, we say anal canal. If it is upper part, sigmoid, we say sigmoid, please. Okay. So that is so the same thing here. Meconium is so that means this communication, this fistula can be with the in the prostate, okay, with the but you know the communication is not between the prostatic urethra and the hindgut. Okay, very important to know that. I told you fistula is communication between the two epithelia. So the epithelium now of the urethra in the prostate and the epithelium of the rectum. Okay, so very important to know that. So this baby, like now, okay, example, this baby was born, and you can see it's a male baby. The scrotum is normal, penile is okay, umbilical is okay, everything is okay. Maybe the lower limbs are okay. But look at here, no anus in this baby. So you have to take him to the surgeons. They will decide when. Usually they wait until he is maybe a few months old. Then they bring him and then they create the anus for him or her. And they will give the patient, their mothers or parents, some mode of what to do when they go back home. Usually you have to dilate the anus repeatedly. Okay, you have to dilate it repeatedly. Okay. Any questions so far, please? No question?
No.
Okay, good. Okay, so it's simple. I think that's the end. That is the end of the. Okay. So if you have a question, I think I'll just drop this on your WhatsApp group, and that's all. This is my last lecture for this semester, isn't it?
Yes.
Yes, doctor.
Okay, very good. We tried.